Welcome to this presentation on Adult Type Diffuse Gliomas, Clinical Diagnosis and Management. I am Professor Ossama Yassin Mansour, specializing in neurology and interventional neuroradiology. Adult Type Diffuse Gliomas represent the most common malignant primary brain tumors in adults, yet they remain a formidable clinical challenge due to their aggressive nature and poor prognosis. Despite their relative rarity compared to benign brain tumors or metastases, gliomas carry significant morbidity and mortality. Over the past 15 years, major advances have been made in understanding these tumors at a molecular level. The 2021 WHO classification now incorporates genetic markers such as IDH mutations and 1p/19q codeletions, which have refined tumor classification beyond traditional histology and improved prognostication. Clinically, adult-type diffuse gliomas are categorized into three main entities: IDH-wildtype glioblastomas, IDH-mutant astrocytomas, and IDH-mutant 1p/19q codelated oligodendrogliomas. Glioblastomas in particular are the most common and aggressive subtype, with a median survival of just 15 to 18 months despite current therapies. The only well-established risk factor is therapeutic ionizing radiation, while protective factors such as atopic conditions and low-dose aspirin use have been identified. Diagnosis relies heavily on MRI with contrast, which typically reveals infiltrative, ring-enhancing lesions with central necrosis and surrounding edema. The clinical presentation varies depending on tumor location, but often includes focal neurological deficits, seizures, and signs of increased intracranial pressure. Management requires a multidisciplinary approach involving neuro-oncologists, neurosurgeons, radiation oncologists, and general neurologists. While molecular advances have paved the way for targeted therapies in select subtypes, overall survival gains remain limited, underscoring the urgent need for ongoing research and clinical trials. In this lecture, we will delve deeper into the diagnostic criteria, molecular features, and evolving management strategies that. As we begin our discussion on adult-type diffuse gliomas, it's important to recognize that gliomas are the most common malignant primary brain tumors in adults. Although their incidence is relatively low, about 5 cases per 100,000 population annually, the impact of these tumors is profound due to their aggressive nature and the significant morbidity and mortality they cause. Glioblastomas, in particular, represent nearly half of all malignant primary CNS tumors, accounting for 9.1%, and about 14.3% of all primary CNS tumors overall. This highlights their prominence and clinical importance. Despite advances in our understanding of glioma biology, especially with molecular characterization improving diagnostic accuracy and tumor classification, survival outcomes have barely improved over the past decades. The median survival for glioblastoma patients remains dismal, typically around 15 to 18 months, with a 5-year survival rate under 7%. This underscores the urgent need for better therapeutic strategies. Managing these complex tumors requires a coordinated multidisciplinary team. Neuro-oncologists, neurosurgeons, radiation oncologists, neurologists, and supportive care specialists all play vital roles in optimizing outcomes. While molecular insights have paved the way for targeted therapies in some glioma subtypes, the overarching challenge remains translating these advances into meaningful survival benefits for patients. In summary, gliomas, especially glioblastomas, remain formidable clinical entities. The combination of aggressive tumor biology, limited treatment efficacy, and the delicate nature of brain tissue necessitates comprehensive, collaborative care to manage both the disease and its impact on patients' quality of life. Thank you for joining me as we delve into glioblastomas, which represent one of the most aggressive and lethal primary brain tumors encountered in adults. Glioblastomas account for nearly half of all malignant primary CNS tumors, with an incidence peaking at about 3.23 cases per 100,000 people annually. Notably, these tumors disproportionately affect males, with a 1.6-fold higher incidence compared to females, and are more prevalent among white populations. The median age at diagnosis is around 65 years, with the highest incidence observed in individuals aged 75 to 84. Unfortunately, Despite advances in molecular classification and diagnostic tools, the prognosis remains dismal. Median overall survival ranges from 15 to 18 months, and the 5-year survival rate is under 7%, underscoring the aggressive nature of this disease. Etiologically, glioblastomas largely arise sporadically, with most cases lacking a clearly defined cause. Therapeutic ionizing radiation remains the only well-established risk factor, while some atopic conditions and long-term low-dose aspirin use have been suggested to confer modest protective effects. Germline mutations linked to hereditary cancer syndromes account for less than 5% of cases, so routine germline testing is not standard practice. Clinically, glioblastomas present variably depending on tumor location, often manifesting as focal neurological deficits, seizures, or symptoms of increased intracranial pressure. Imaging with contrast-enhanced MRI is the diagnostic gold standard, typically revealing a ring-enhancing lesion with central necrosis and peritumoral edema. Understanding these epidemiologic and clinical facets is crucial for timely diagnosis and multidisciplinary management, which remains the cornerstone of care as we strive to improve outcomes for these patients. As we review the clinical manifestations of adult-type diffuse gliomas, it is important to recognize that the presentation is highly dependent on the tumor's location within the brain. For example, tumors affecting motor cortex regions commonly produce hemiparesis, while those involving language areas may cause aphasia. Sensory deficits and visual field disturbances are also frequent focal symptoms, reflecting involvement of corresponding cortical or subcortical pathways. Beyond these focal neurological signs, patients often present with more global symptoms such as gait imbalance and urinary incontinence, which suggest involvement of deeper brain structures or widespread disruption of neural networks. Cognitive and behavioral changes are particularly prominent in older adults and can manifest as subtle neurocognitive decline or more overt personality alterations. These symptoms are often underappreciated but critically impact quality of life. Elevated intracranial pressure is another key clinical feature, manifesting as headache, nausea, and vomiting. These symptoms typically arise from mass effect or obstructive hydrocephalus caused by tumor growth. Additionally, seizures occur in approximately 20 to 40% of glioblastoma patients, usually starting focally in the region of the tumor. Seizures may sometimes be the initial presenting symptom, underscoring the importance of considering gliomas in the differential diagnosis of new-onset focal seizures in adults. In summary, the clinical picture of adult diffuse gliomas is multifaceted, ranging from focal neurological deficits to global cognitive impairments and signs of raised intracranial pressure. Awareness of these diverse manifestations facilitates timely diagnosis and comprehensive management. Thank you for advancing to this critical slide on imaging in adult-type diffuse gliomas. Brain MRI with contrast remains the gold standard diagnostic modality for these tumors. Unlike CT scans, which have a limited role primarily reserved for patients who cannot undergo MRI, contrast-enhanced MRI provides unparalleled detail about the tumor's extent and characteristics, which is essential for diagnosis, surgical planning, and treatment monitoring. Typically on MRI, these gliomas appear as infiltrative heterogeneous lesions with ring enhancement after contrast administration, reflecting the disrupted blood-brain barrier. On T1-weighted images, you often see central areas of necrosis, which is a hallmark of high-grade tumors like glioblastomas. Surrounding this necrotic core, T2-weighted and FLAIR sequences demonstrate hyperintensity, indicating a combination of vasogenic edema and infiltrative tumor cells extending into adjacent white matter. Diffusion-weighted imaging adds further diagnostic specificity by helping differentiate gliomas from other ring-enhancing lesions, such as CNS lymphomas or abscesses, which typically show restricted diffusion centrally. This distinction is crucial because management strategies differ dramatically. It's important to note that some molecularly defined glioblastomas may lack classic histologic features and show only faint or patchy enhancement, underscoring the need for integrating molecular diagnostics with imaging findings. Overall, MRI not only guides diagnosis, but also helps define the tumor's invasiveness and guides multidisciplinary treatment planning. As we focus on distinguishing glioblastomas from other pathologies, it is crucial to recognize that several non-neoplastic conditions can radiographically mimic glioblastomas, posing diagnostic challenges. Common mimics include brain abscesses, subacute strokes, and tumefactive multiple sclerosis lesions. Each of these can present with imaging features such as ring enhancement or mass effect that overlap with glioblastomas, but their management differs significantly. Clinical history and patient age play a pivotal role in guiding accurate diagnosis. For example, a history of infection or immunosuppression may point toward an abscess, while vascular risk factors might suggest a stroke. Tumefactive MS lesions often occur in younger patients with other demyelinating symptoms. When the clinical presentation and imaging findings are discordant or ambiguous, a short-term follow-up MRI is recommended rather than immediate invasive procedures. This allows us to monitor lesion evolution, which can help differentiate neoplastic from non-neoplastic processes. Additional diagnostic workup such as lumbar puncture, total spine MRI, or whole-body PET scans is generally not indicated unless there is a specific clinical suspicion for systemic disease or infection. Overuse of these tests can lead to unnecessary delays and patient anxiety. Ultimately, a multidisciplinary approach integrating clinical, radiologic, and sometimes molecular data is essential to avoid misdiagnosis and to optimize patient management. This careful differentiation ensures that patients receive timely and appropriate treatment tailored to their underlying condition. As we focus on symptomatic management of adult-type diffuse gliomas, corticosteroids play a critical role, primarily by reducing peritumoral edema. This edema contributes significantly to neurological symptoms such as headache, focal deficits, and increased intracranial pressure, so alleviating it can provide rapid, though temporary, symptomatic relief. Dexamethasone is the corticosteroid of choice in this setting. Its preference stems from its low mineralocorticoid activity, which reduces risks of fluid retention and hypertension, and its long half-life combined with high bioavailability, allowing for convenient dosing schedules and consistent therapeutic levels. Typically, we start with 12 to 16 milligrams daily, but many patients respond well to lower doses in the range of 4 to 8 milligrams daily, which helps minimize side effects. However, we must be vigilant about the well-recognized long-term adverse effects of corticosteroid use. These include adrenal insufficiency, hyperglycemia and diabetes, increased susceptibility to infections, and bone demineralization leading to fractures. Thus, the key principle is to use the minimum effective dose for the shortest duration possible. An important clinical caution: if primary CNS lymphoma is in the differential diagnosis, corticosteroids should be withheld until after biopsy. Steroids can dramatically reduce lymphoma cellularity, potentially yielding non-diagnostic tissue and delaying definitive diagnosis. In summary, while corticosteroids are invaluable for symptom control in glioma patients, their administration requires careful balancing of benefits and risks, always prioritizing the shortest and lowest effective dosing to optimize patient outcomes. As we focus on surgical management of adult-type diffuse gliomas, the primary objective is achieving a maximal safe resection through microsurgical techniques. This means removing as much of the tumor as possible while preserving neurological function. Safety is paramount because post-operative morbidity, such as new neurological deficits, can significantly worsen patient outcomes and quality of life. The benefits of maximal resection are multifold. First, greater extent of resection correlates strongly with improved overall survival, a critical consideration given the aggressive nature of these tumors. Second, obtaining adequate tumor tissue allows for precise histologic and molecular diagnosis, which is essential in this era of integrated classification and personalized therapy. Third, debulking the tumor reduces mass effect, alleviating symptoms such as headaches, focal neurological deficits, and seizures. This also facilitates a more rapid reduction in corticosteroid use, minimizing steroid-related side effects. When a tumor is deemed unresectable due to location or patient factors, alternative approaches come into play. Stereotactic biopsy provides diagnostic tissue with minimal risk, while laser interstitial thermal ablation offers a minimally invasive option for local tumor control in select cases. Post-operatively, contrast-enhanced brain MRI within 48 to 72 hours is recommended to accurately assess residual tumor burden. This early imaging helps guide adjuvant treatment decisions and provides a baseline for future surveillance. In summary, maximal safe resection remains the cornerstone of surgical management for adult-type diffuse gliomas, balancing oncologic control with preservation of neurological function to optimize patient outcomes. As we move to adjuvant treatment modalities beyond surgery, it's important to emphasize that surgical resection followed by combined chemoradiation remains the cornerstone of therapy for adult-type diffuse gliomas, particularly glioblastomas. The standard radiation therapy protocol involves delivering a total dose of 60 gray GY, fractionated into 30 daily treatments over 6 weeks. This fractionation balances maximizing tumor cell kill while minimizing damage to surrounding normal brain tissue. Concurrent with radiation, Temozolomide chemotherapy is administered daily at 75 milligrams per square meter of body surface area, followed by 6 cycles of adjuvant temozolomide given in 28-day cycles. This combined approach, known as the STOP protocol, was a landmark advancement that improved median survival from 12.1 months with radiation alone to approximately 14.6 months, representing a meaningful benefit in this otherwise devastating disease. A critical prognostic and predictive biomarker in this context is MGMT promoter methylation. Patients whose tumors harbor MGMT promoter methylation tend to respond better to alkylating agents like temozolomide because methylation silences the DNA repair enzyme MGMT, reducing the tumor's ability to repair chemotherapy-induced DNA damage. Despite these advances, it's crucial to recognize that outcomes remain modest, highlighting the urgent need for continued research into novel therapeutics and personalized treatment strategies based on molecular tumor profiling. This multidisciplinary approach integrates neurosurgery, radiation oncology, and medical oncology to optimize patient outcomes. As we review this case of a 64-year-old man presenting with a new onset seizure and cognitive impairment, it exemplifies the typical clinical and molecular profile of an IDH-wildtype glioblastoma, the most common and aggressive adult-type diffuse glioma. The radiographic findings here, a predominantly infiltrative mass in the right frontoparietal white matter with a small focus of enhancement, highlight a key diagnostic challenge. Unlike classic glioblastomas that often show robust ring enhancement and necrosis, this lesion lacks overt histologic features such as mitosis and necrosis but harbors molecular hallmarks that confirm its aggressive nature. Molecular profiling is crucial and in this case reveals IDH wild-type status, presence of a TERT promoter mutation, and an unmethylated MGMT promoter. These molecular features have prognostic and therapeutic implications. IDH wild-type glioblastomas generally portend a poorer prognosis and are less responsive to alkylating agents like temozolomide when the MGMT promoter is unmethylated. The TERT promoter mutation is associated with enhanced tumor proliferation and worse outcomes. Despite standard chemoradiation therapy, this patient experienced disease progression within 1 year, underscoring the aggressive biology and therapeutic resistance typical of IDH wild-type glioblastomas. This case reinforces the importance of integrating molecular diagnostics into our clinical approach, informing prognosis and guiding management decisions. It also highlights the urgent need for novel therapies tailored to the molecular landscape of these tumors to improve patient outcomes. As we discuss tumor-treating fields or TT fields, it's important to recognize this modality as an FDA-approved adjunctive therapy specifically for newly diagnosed glioblastomas, used alongside the standard chemotherapeutic agent temozolomide. TT fields delivers low-intensity, intermediate frequency, alternating electric fields at around 200 Hz through 4 transducer arrays applied to the shaved scalp. Patients are required to wear these arrays for at least 18 hours a day, which can pose practical and quality of life challenges. Mechanistically, these alternating electric fields disrupt mitosis by interfering with microtubule polymerization and the alignment of charged molecules during cell division, ultimately inhibiting tumor growth. While clinical trial data have demonstrated a modest survival benefit, the landmark study reported an overall survival extension from 19.8 months without TT fields to 24.5 months with it, and a 2-year survival improvement from 28% to 36%. This gain must be balanced against the burdens of continuous device use and potential skin irritation. Despite these encouraging results, TT fields has not been widely adopted in clinical practice. This is largely due to concerns about patient adherence, given the device's cumbersome nature, as well as mixed perceptions regarding its impact on quality of life. Therefore, TT-Fields represents an important, though still somewhat niche, tool in our therapeutic arsenal against glioblastoma, emphasizing the need for multidisciplinary care and individualized patient counseling when considering this option. Thank you for advancing to this important slide on special considerations for older adults with adult type diffuse gliomas. In clinical practice, we generally consider patients over 60, 65, or 70 years old as older adults, though the exact cutoff may vary. This age group presents unique challenges due to their generally poorer prognosis and the frequent presence of comorbidities, which complicate both the disease course and treatment tolerance. Older age remains one of the most significant negative prognostic factors in glioma management. These patients are more vulnerable to treatment-related toxicities, necessitating a more nuanced, modified approach to therapy. For patients aged 65 and above, hypofractionated radiation therapy, typically 40 GY delivered over 15 fractions in 3 weeks, has become a preferred regimen. This shorter course strikes a balance between efficacy and minimizing toxicity, which is crucial given their often limited physiological reserve. Concurrent and adjuvant temozolomide chemotherapy can be incorporated, but here molecular markers play a critical role. The MGMT promoter methylation status guides treatment decisions. Patients with methylated MGMT are better candidates for combination therapy or temozolomide alone, as they tend to respond more favorably to alkylating agents. Conversely, for those with unmethylated MGMT, single modality treatment with radiation alone is often considered to avoid unnecessary chemotherapy toxicity without clear benefit. In summary, managing gliomas in older adults requires personalized treatment plans that integrate age, functional status, molecular markers, and patient preferences to optimize outcomes while minimizing harm. This tailored approach reflects the evolving paradigm in neuro-oncology that balances efficacy with quality of life in this vulnerable population. Thank you for your attention as we now focus on the management of recurrent glioblastomas, a particularly challenging clinical scenario. Despite aggressive initial treatment, including maximal safe resection, radiation, and temozolomide-based chemotherapy, virtually all glioblastoma patients experience tumor progression. Unfortunately, the prognosis at recurrence remains poor, with median survival times in clinical trials typically ranging from 6 to 9 months. Given the limited efficacy of current therapies, our primary recommendation is to strongly encourage eligible patients with good performance status to participate in clinical trials. These trials are critical for advancing our understanding and developing more effective treatments. Various investigational approaches have been explored, including targeted therapies aimed at molecular alterations, immunotherapies designed to harness the patient's immune system, and oncolytic viral therapies. However, to date, none have demonstrated a significant improvement in overall survival in large-scale studies. For patients who are not candidates for clinical trials, management involves tailored salvage chemotherapy regimens guided by prior treatments, tumor molecular profile, and patient-specific factors such as functional status and comorbidities. Options may include lomustine, bevacizumab for symptomatic edema control, or re-challenge with temozolomide in select cases. Importantly, care should be multidisciplinary, with attention to maintaining quality of life and symptom control. In summary, recurrent glioblastoma remains a disease with a dire prognosis, and while clinical trials represent the best hope for improved outcomes, individualized salvage therapies and supportive care remain essential components of management. As we turn to chemotherapy regimens for recurrent glioblastomas, it's crucial to recognize that despite advances in molecular profiling, effective systemic treatments remain limited and recurrence is almost inevitable. The alkylating agents, lomustine, temozolomide, and camustine, are mainstays in managing recurrent disease due to their ability to cross the blood-brain barrier and induce DNA damage in tumor cells. Lomustine, administered at 110 milligrams per square meter every 6 to 8 weeks, is often favored for its oral dosing convenience, but clinicians must vigilantly monitor for bone marrow suppression and fatigue, which can limit dosing. Carmustine shares a similar toxicity profile, including potential pulmonary fibrosis, necessitating pulmonary function assessments during treatment. Temozolomide remains a versatile agent with multiple scheduling options, allowing tailored dosing to balance efficacy and toxicity, primarily cytopenias and gastrointestinal side effects. Bevacizumab, an anti-VEGF monoclonal antibody, targets tumor angiogenesis and is used to manage symptomatic edema and progression. Given its mechanism, hypertension and thromboembolic events are significant concerns requiring careful cardiovascular monitoring. In clinical practice, choosing a regimen involves weighing prior therapies, patient tolerance, and goals of care. Multidisciplinary coordination ensures optimal sequencing and management of adverse effects to maintain quality of life. While these agents offer modest benefits, ongoing trials aim to improve outcomes by integrating molecular insights and novel therapies. Certainly, here are the speaker notes for slide 15 on IDH-mutant gliomas, a major hallmark in neuro-oncology. As we delve deeper into adult-type diffuse gliomas, it's critical to highlight the pivotal role of IDH mutations, one of the major milestones in neuro-oncology over the past decade. IDH, or isocitrate dehydrogenase, mutations are now recognized as defining molecular markers that not only refine tumor classification but also have prognostic and therapeutic implications. IDH-mutant gliomas represent about 12% of all gliomas and roughly 4.6% of primary brain tumors overall. This group primarily includes two important subtypes: IDH-mutant astrocytomas and oligodendrogliomas, characterized by codeletion of chromosomal arms 1p and 19q. The identification of these molecular alterations has revolutionized our diagnostic approach, moving beyond traditional histology alone. From a pathophysiological perspective, the mutation in IDH enzymes confers a neomorphic activity, converting alpha-ketoglutarate into an oncometabolite called D2-hydroxyglutarate, or D2HG. This metabolite accumulates at supraphysiologic levels within tumor cells and plays a central role in tumorigenesis by affecting epigenetic regulation, cellular differentiation, and the tumor microenvironment. Essentially, D2HG acts as a metabolic driver, fostering oncogenic transformation and maintenance. Clinically, recognizing IDH mutation status informs prognosis. Patients with IDH-mutant gliomas generally have better overall survival compared to their IDH-wildtype counterparts. Moreover, ongoing clinical trials are investigating targeted therapies against this metabolic pathway, aiming to exploit this vulnerability. In summary, IDH mutations represent a fundamental biomarker that has reshaped how we diagnose, classify, and ultimately manage adult diffuse gliomas, emphasizing the integration of molecular genetics into everyday neuro-oncologic practice. As we examine the epidemiological characteristics of IDH-mutant gliomas, it's important to contextualize these findings within the broader landscape of adult-type diffuse gliomas. Unlike IDH-wildtype glioblastomas, which typically present in older adults with a median age around 65, IDH-mutant gliomas affect a younger population, with the highest incidence observed between 35 and 44 years of age. This distinction is clinically relevant, as it influences both prognosis and therapeutic strategies. More specifically, within the IDH-mutant glioma subgroup, astrocytomas tend to peak slightly earlier, between 30 and 34 years, whereas oligodendrogliomas peak between 40 and 44 years. This age distribution reflects the underlying biology and molecular pathways driving tumor development. Notably, these tumors show a higher incidence in males compared to females and are more prevalent among white individuals than other racial groups, highlighting potential genetic or environmental influences that warrant further investigation. A fascinating genetic link exists between Olea disease, a rare skeletal disorder characterized by somatic mosaic IDH mutations, and an increased risk of developing IDH-mutant gliomas. This association underscores the role of IDH mutations not only in tumorigenesis, but also in broader systemic pathologies. Understanding these epidemiological nuances helps us tailor clinical suspicion, diagnosis, and management approaches for adult patients presenting with diffuse gliomas, ensuring that molecular characteristics guide our decision-making for optimal patient outcomes. As we focus now on IDH-mutant gliomas, it's important to recognize that these tumors generally demonstrate a more indolent biological behavior compared to their IDH-wildtype counterparts. This slower progression often translates into a relatively better prognosis, though they remain serious and incurable tumors requiring careful management. Clinically, IDH-mutant gliomas are highly epileptogenic. Approximately 80% of patients present initially with seizures, frequently without accompanying focal neurological deficits. This high seizure propensity is a key diagnostic clue and often prompts neuroimaging that leads to the tumor's discovery. On MRI, these gliomas typically manifest as expansile lesions that are hyperintense on T2-weighted and FLAIR sequences. A noteworthy imaging hallmark is the T2 FLAIR mismatch sign, which is highly specific for astrocytomas within this group. This sign helps differentiate astrocytomas from oligodendrogliomas, the latter of which often involve cortical regions and characteristically demonstrate calcifications on imaging. Advanced imaging techniques further enhance our diagnostic accuracy. Mr. spectroscopy, for example, can non-invasively detect the accumulation of the oncometabolite D2-hydroxyglutarate, D2-HG, which accumulates specifically in IDH-mutant tumors. Detecting D2-HG offers a valuable molecular signature that supports diagnosis without the need for invasive biopsy in select cases. Understanding these clinical and radiographic features is crucial for early diagnosis, guiding biopsy, and tailoring management strategies for patients with IDH-mutant gliomas, ultimately improving patient care within a multidisciplinary framework. As we review the CHO grading system for IDH-mutant astrocytomas, it's important to appreciate how this classification integrates both histologic and molecular features to stratify tumor aggressiveness and guide clinical management. Starting with CNS WHO grade 2 astrocytomas, these tumors are well differentiated and lack anaplasia, which means the cells appear relatively normal under the microscope. Mitotic activity is absent or very low, indicating limited cell division. Importantly, these tumors do not exhibit microvascular proliferation or necrosis, two hallmarks of more aggressive gliomas. Additionally, there are no deletions of CDKN2A or CDKN2B, tumor suppressor genes whose loss correlates with worse prognosis. Moving to CNS WHO grade 3, these tumors show focal or dispersed anaplasia, meaning there are areas where cells look more abnormal and aggressive. There is significant mitotic activity reflecting increased proliferation. However, like grade 2, they still lack microvascular proliferation, necrosis, and deletions of CDKN2A/B, which keeps them distinct from the highest grade. Finally, CNS WHO grade 4 represents the most aggressive IDH-mutant astrocytomas. These tumors demonstrate microvascular proliferation and/or necrosis, classic features of malignancy indicating rapid growth and poor blood supply leading to tissue death. Alternatively, the presence of homozygous deletion of CDKN2A or CDKN2B alone also upgrades the tumor to grade 4, highlighting the prognostic importance of molecular alterations beyond morphology. This nuanced grading system underscores how integrating histology with molecular markers improves diagnostic precision and prognostication, which is critical for tailoring treatment strategies and counseling patients. Understanding these distinctions helps clinicians anticipate tumor behavior and select appropriate therapies within multidisciplinary care frameworks. Certainly, here are the speaker notes for slide 19 on molecular characteristics and genetic alterations in adult type diffuse gliomas. On this slide, we delve into the critical molecular underpinnings that define adult type diffuse gliomas, focusing particularly on IDH-mutant astrocytomas and IDH-mutant oligodendrogliomas. Understanding these molecular characteristics is essential, as they not only refine our diagnostic accuracy, but also guide prognosis and therapeutic strategies. Starting with IDH-mutant astrocytomas, the hallmark is mutations in the IDH1 or IDH2 genes. These mutations are almost invariably accompanied by alterations in the ATRX gene, which manifests as nuclear loss of ATRX expression on immunohistochemistry. Additionally, TP53 mutations are highly prevalent in this subtype and can be detected by strong nuclear p53 immunoreactivity. These molecular changes help distinguish astrocytomas from oligodendrogliomas and have significant prognostic implications. When we consider histologic features, Higher grade astrocytomas exhibit increased cellularity, marked nuclear atypia, brisk mitotic activity, microvascular proliferation, and necrosis. These features correlate with more aggressive behavior and worse outcomes. Turning to IDH-mutant oligodendrogliomas, these require the presence of both an IDH1 or IDH2 mutation and a combined 1p/19q chromosomal codeletion for diagnosis. This codeletion is a defining molecular signature that differentiates oligodendrogliomas from astrocytomas. Moreover, these tumors often harbor TERT promoter mutations, specifically hotspot variations, and alterations in genes such as CIC and FUBP1, which contribute to their molecular landscape. The integration of these molecular markers into the WHO classification has revolutionized glioma diagnostics, moving beyond histology alone to a more precise, genetically informed categorization. This not only improves prognostication but also increasingly informs clinical trial design and therapeutic decisions, underscoring the importance of certainly. Here are comprehensive speaker notes for slide 20, surgical resection strategy for IDH-mutant gliomas. As we focus on the surgical management of IDH-mutant gliomas, it's critical to emphasize that extensive surgical resection represents the foundational first step in treatment. Our primary goal is to remove not only all the contrast-enhancing tumor components visible on MRI, but also the non-enhancing infiltrative disease. This approach is particularly important in IDH-mutant gliomas because these tumors often have a more indolent course compared to IDH-wildtype glioblastomas, and maximal resection can significantly influence survival and quality of life. The benefits of aggressive resection are multifold. First, it provides a larger tissue sample, enabling comprehensive molecular and histopathological diagnosis, which is essential given the updated WHO classification that integrates molecular markers such as IDH mutation status and 1p/19q codeletion. This molecular information guides prognosis and subsequent adjuvant therapy decisions. Second, extensive resection has been consistently associated with a significant reduction in seizure frequency. Seizures are a common and debilitating symptom in these patients, and surgical debulking often improves seizure control, reducing reliance on anti-epileptic medications. Third, and most importantly, maximal safe resection improves overall clinical outcomes, including progression-free and overall survival, for both low-grade and high-grade IDH-mutant gliomas. The key is balancing aggressive tumor removal while preserving neurological function. Postoperatively, MRI with contrast should be obtained within 24 to 48 hours. Early imaging helps evaluate the extent of resection before significant postoperative changes like cerebral edema develop. However, a follow-up MRI at 1 to 2 months post-surgery can provide a more accurate assessment of residual tumor once postoperative edema and inflammation have subsided. In summary, the surgical strategy for IDH-mutant gliomas hinges on maximal safe resection targeting both enhancing and non-enhancing tumor. Thank you for advancing to this critical slide on treatment decisions following surgical resection of adult type diffuse gliomas, particularly focusing on IDH-mutant tumors. Despite advancements in molecular diagnostics that have refined tumor classification, post-surgical management remains an area of ongoing debate and clinical judgment. For newly diagnosed IDH-mutant gliomas, the standard approach broadly recommends postoperative radiation combined with alkylating chemotherapy for all grade 3 and 4 tumors, reflecting their higher malignant potential. This combined modality aims to delay progression and improve survival, as supported by multiple clinical trials. When it comes to grade 2 tumors, the picture is more nuanced. The majority of these patients are advised to receive post-operative adjuvant therapy as well, given the risk of progression. However, there exists a subset of low-risk grade 2 patients who may be candidates for observation alone. Traditional criteria defining low risk include a gross total resection, excellent performance status, younger age, typically under 40 years, and importantly, the presence of 1p/19q codeletion, which correlates with a more favorable prognosis. It's important to emphasize, though, that there is no universally accepted definition of low risk, and treatment decisions must be individualized. Factors such as patient preference, tumor biology, and emerging molecular data all play a role. Multidisciplinary discussion is essential to balance the benefits of early intervention against potential treatment-related toxicities. In summary, while postoperative radiation and chemotherapy are standard for higher-grade IDH-mutant gliomas, selective observation remains a viable strategy for carefully chosen low-risk Grade 2 patients. This approach exemplifies the evolving personalized management paradigm in neuro-oncology. As we review the essential points for clinical practice in managing adult-type diffuse gliomas, it's critical to emphasize that accurate diagnosis hinges on a multidisciplinary integration of clinical presentation, advanced imaging, histopathology, and molecular profiling. MRI, with contrast, remains our gold standard imaging modality, offering detailed visualization of tumor characteristics such as ring enhancement, necrosis, and infiltrative patterns, which are pivotal for distinguishing glioblastomas from other lesions. Maximal safe surgical resection is foundational, aiming to reduce tumor burden while preserving neurological function. This approach not only alleviates mass effect, but also provides tissue for definitive diagnosis and molecular studies. Following surgery, the current standard of care for glioblastomas is adjuvant chemoradiation, typically with temozolomide, which has demonstrated survival benefits despite the overall poor prognosis. A key prognostic and predictive biomarker is the IDH mutation status. IDH-mutant gliomas generally have a more favorable prognosis and may respond differently to therapy, underscoring the importance of molecular classification in tailoring treatment. Given the complexity of these tumors and the rapidly evolving landscape of targeted therapies and clinical trials, a multidisciplinary team, including neuro-oncology, neurosurgery, radiation oncology, neuropathology, and supportive care specialists, is essential to optimize patient outcomes. Finally, I strongly encourage clinical trial participation. It offers patients access to novel therapies and contributes to advancing our understanding and management of these challenging tumors. As we conclude today's presentation on adult-type diffuse gliomas, I want to sincerely thank you all for your attention and engagement. The management of gliomas remains one of the most challenging areas in neuro-oncology due to their inherent complexity and aggressive nature. Despite significant advances in molecular diagnostics that have refined our understanding and classification, particularly the identification of IDH mutations and 1p/19q codeletions, the prognosis for most patients, especially those with glioblastoma, remains poor. This underscores the vital importance of a multidisciplinary approach. Optimal care demands collaboration among neuro-oncologists, neurosurgeons, radiation oncologists, epileptologists, and general neurologists, alongside supportive services such as neuropsychology and palliative care. Each discipline contributes unique expertise that collectively improves diagnostic accuracy, therapeutic decision-making, and ultimately patient outcomes. Furthermore, integrating molecular insights into clinical practice allows us to tailor therapies more precisely and participate in clinical trials targeting specific glioma subtypes. While current treatments offer limited survival benefit, ongoing research is promising, and our commitment to evidence-based medicine will continue to drive progress. I welcome your questions and look forward to a robust discussion on how we can further advance care for patients living with these devastating tumors. Together, through shared knowledge and collaboration, we can strive to improve both survival and quality of life for our patients. As we focus on seizure management in glioblastoma patients, it's important to recognize that seizures affect approximately 20 to 40% of these individuals, most commonly presenting as focal seizures. This incidence underscores the clinical significance of seizures as a substantial source of morbidity in glioblastoma care. The 2021 SNO-ENO guidelines provide a critical update. Routine prophylactic anticonvulsant therapy is not recommended in patients with newly diagnosed brain tumors who have never had seizures. This represents a shift from earlier practices where prophylaxis was more commonly employed. The rationale is that prophylactic anticonvulsants have not demonstrated clear benefit in preventing first seizures and can expose patients to unnecessary side effects and drug interactions. Regarding perioperative management, evidence remains insufficient to support routine use of anticonvulsants during the peri- or postoperative period, again emphasizing an individualized approach based on clinical context. When anticonvulsants are indicated, selecting agents with minimal hepatic enzyme induction is crucial. Levetiracetam and lacosamide are preferred over older agents like phenytoin or carbamazepine because they have fewer interactions with chemotherapy drugs and other medications, thereby reducing the risk of adverse effects and maintaining therapeutic efficacy. Overall, seizure management in glioblastoma demands a tailored strategy that balances seizure control with minimizing polypharmacy and drug interactions, integrating input from neuro-oncology, neurology, and epilepsy specialists to optimize patient quality of life and treatment outcomes. As we focus on advanced surgical techniques and intraoperative monitoring, it's important to emphasize how these tools have revolutionized the surgical management of adult-type diffuse gliomas, enabling us to maximize tumor resection while minimizing neurological deficits. First, 5-aminolevulinic acid, or 5-ALA, is a game-changer in tumor visualization. Administered preoperatively, it causes tumor cells to fluoresce under a specific light wavelength, allowing surgeons to distinguish tumor tissue from normal brain more precisely during resection. This fluorescence-guided surgery has been shown to increase the extent of resection, which correlates with improved patient outcomes. Awake mapping is another critical technique, especially when tumors are near eloquent cortex areas responsible for language or motor function. By keeping the patient awake and interactive during surgery, we can perform real-time functional mapping and avoid damaging essential brain regions, preserving neurological function. Preoperative functional MRI complements this by identifying critical motor and language areas before surgery, guiding surgical planning and reducing risks. Intraoperative MRI takes this further by providing real-time imaging during surgery. Surgeons can assess the extent of resection immediately and decide if additional tumor removal is feasible, improving surgical precision. Neuromonitoring plays a continuous role throughout surgery, allowing us to track motor and sensory pathways and detect any changes that may indicate impending injury, enabling immediate corrective actions. Lastly, none of these techniques can be safely or effectively implemented without a dedicated multidisciplinary support team, including anesthesia experts skilled in neuroanesthesia and neurointensive care specialists who manage patients postoperatively. Together, these advanced techniques embody the principle of maximal safe resection, pushing the frontiers of tumor removal while preserving the patient's neurological integrity, which remains the cornerstone of glioma surgery. As we focus on MGMT promoter methylation, it's crucial to appreciate its dual role as both a prognostic and predictive biomarker in adult-type diffuse gliomas, particularly glioblastomas. The MGMT gene encodes a DNA repair enzyme that counteracts the effects of alkylating agents like temozolomide by removing alkyl groups from the O6 position of guanine, thereby repairing the DNA damage these drugs induce. When the MGMT promoter is methylated, this gene is epigenetically silenced, leading to reduced MGMT protein expression. Consequently, tumor cells are less capable of repairing temozolomide-induced DNA damage, resulting in enhanced chemosensitivity. Clinically, this translates into better responses to temozolomide, improved progression-free and overall survival, and makes these patients ideal candidates for combined chemoradiation protocols. Conversely, an unmethylated MGMT promoter indicates intact DNA repair capacity, predicting a poor response to temozolomide. In such cases, especially among older adults or those with poor performance status, alternative strategies such as radiation alone may be more appropriate to avoid unnecessary chemotherapy toxicity. Therefore, determining MGMT methylation status is an essential step in personalized treatment planning. It guides therapeutic decisions by identifying patients likely to benefit from alkylating chemotherapy and those who may require alternative approaches. This tailored strategy exemplifies precision oncology in neuro-oncology, aiming to optimize outcomes while minimizing harm. Certainly, here are the detailed speaker notes for slide 27 on mastospectroscopy and molecular imaging in IDH-mutant gliomas. As we delve deeper into advanced imaging techniques for adult-type diffuse gliomas, Mr. spectroscopy and molecular imaging have emerged as invaluable tools, particularly in the context of IDH-mutant gliomas. Mr. spectroscopy allows us to non-invasively detect and quantify the oncometabolite 2-hydroxyglutarate, or D2HG, which accumulates specifically in tumors harboring IDH mutations. This specificity is crucial because it means we can confirm IDH mutation status without needing an invasive biopsy, which is a significant advantage for patient care. Clinically, this has multiple important applications. First, Mr. spectroscopy provides a quantitative assessment of tumor metabolism, giving us insights beyond what conventional MRI sequences can reveal. It's repeatable and non-invasive, enabling longitudinal monitoring of tumor burden and progression over time. Moreover, with the advent of targeted therapies such as IDH inhibitors, Mr. spectroscopy becomes a powerful tool to monitor therapeutic response. By tracking changes in D2HG levels, clinicians can assess whether the tumor is responding to treatment, potentially leading to earlier adjustments in management. From a research perspective, molecular imaging techniques are gaining traction as biomarkers in clinical trials. They help us understand tumor biology in vivo and evaluate new drugs more effectively. In summary, Mr. spectroscopy and molecular imaging enhance our diagnostic precision, improve patient monitoring, and support the development of personalized therapies for IDH-mutant gliomas, ultimately aiming to improve outcomes in these challenging tumors. Let me know if you need notes for additional slides or other content. As we focus now on targeted therapy for NTRK fusion gliomas, it's important to understand that this represents a significant advancement in the molecular approach to treating adult-type diffuse gliomas. NTRK gene fusions identify a distinct subset of gliomas driven by oncogenic activation of the neurotrophic tyrosine receptor kinase NTRK proteins. These fusions lead to constitutive activation of the TRK signaling pathway, which promotes tumor growth and survival. TRK inhibitors, such as larotrectinib and entrectinib, are small molecule tyrosine kinase inhibitors specifically designed to target these aberrant NTRK fusion proteins. Larotrectinib has received FDA approval for the treatment of solid tumors harboring NTRK fusions, including gliomas, marking a paradigm shift towards precision oncology. Entrectinib serves as an alternative TRK inhibitor with additional activity against ROS1 and ALK, expanding its therapeutic potential. Clinically, these agents have demonstrated promising outcomes, including durable responses and improved progression-free survival in NTRK fusion-positive glioma patients who otherwise have limited treatment options. Given this, molecular profiling of gliomas should routinely include testing for NTRK fusion status to identify candidates for these targeted therapies early in the treatment course. While these therapies do not yet represent a cure, they exemplify how integrating molecular diagnostics with targeted treatments can personalize and potentially improve management in this challenging patient population. Our multidisciplinary approach must incorporate these advances to optimize care and outcomes. As we look toward future therapeutic strategies in adult-type diffuse gliomas, one of the most promising avenues involves targeting the mutant IDH enzymes with specific inhibitors. Vorasidenib is a first-in-class brain-penetrant IDH inhibitor that selectively targets both IDH1 and IDH2 mutations. These mutant enzymes aberrantly produce the oncometabolite 2-hydroxyglutarate, D2HG, which contributes to tumorigenesis by altering cell differentiation and epigenetic regulation. By inhibiting D2HG production, vorasidenib aims to reverse these oncogenic processes, potentially slowing tumor progression. Currently, vorasidenib is under active clinical investigation in patients with IDH-mutant gliomas, including low-grade gliomas that often harbor these mutations. Early-phase trials have demonstrated favorable safety profiles along with encouraging signals of efficacy, particularly in delaying tumor growth and improving progression-free survival. The potential benefits of this targeted approach are multifaceted. It may provide a means to slow disease progression, improve overall survival, and importantly, reduce treatment-related toxicity compared to conventional cytotoxic therapies. This is critical given the often chronic nature of IDH-mutant gliomas and the need to preserve neurological function over time. Beyond IDH inhibition, the landscape is expanding with emerging immunotherapy approaches and combination strategies that seek to enhance anti-tumor immune responses or synergize with targeted agents. These evolving modalities underscore the importance of a multidisciplinary approach and personalized treatment paradigms, aiming ultimately to transform the prognosis of these challenging tumors. In summary, vorasidenib represents a significant step forward in translating molecular insights into effective, less toxic therapies for patients with IDH-mutant gliomas, heralding a new era of precision neuro-oncology. As we explore the clinical trial landscape for adult type diffuse gliomas, two pivotal studies stand out: the CODEL and CATNON trials. These trials have been instrumental in shaping our current understanding and management of anaplastic gliomas, particularly those harboring IDH mutations. The CODEL trial specifically investigates the efficacy of combining radiation therapy with the PCV chemotherapy regimen, comprising procarbazine, CCNU, lomustine, and vincristine, in patients with anaplastic gliomas. This combination has long been considered a standard of care for selected tumors, especially those with 1p/19q codeletion, such as oligodendrogliomas. The rationale behind PCV is its multi-agent approach targeting different cellular pathways, which has demonstrated improvements in both progression-free and overall survival. On the other hand, the CATNON trial addresses a more challenging subgroup, anaplastic astrocytomas without 1p19q codeletion. This trial evaluates radiation therapy with or without adjuvant chemotherapy, notably PCV, aiming to clarify the benefit of chemotherapy in this molecularly defined group. The results from CATNON have helped refine treatment guidelines by emphasizing the role of chemotherapy in IDH-mutant but non-codeleted tumors. Collectively, these trials underscore the clinical significance of tailoring adjuvant therapy based on molecular markers, moving beyond histology alone. As we continue to integrate these findings into practice, the PCV regimen remains a cornerstone in improving outcomes for patients with specific anaplastic glioma subtypes, highlighting the critical role of multidisciplinary care and personalized medicine in neuro-oncology. Certainly, here are the speaker notes for slide 31 on hereditary cancer syndromes and glioblastoma risk. When discussing glioblastomas, it's important to recognize the role of genetic predisposition, even though it accounts for a relatively small subset of cases. Less than 5% of glioblastoma patients harbor germline mutations that increase their risk. This low incidence means that routine germline genetic testing is not standard practice in most clinical settings. However, identifying patients with hereditary cancer syndromes remains clinically significant, especially for risk assessment and family counseling. Several hereditary syndromes are associated with an elevated risk of glioblastoma. Li-Fraumeni syndrome is characterized by germline mutations in the TP53 tumor suppressor gene, predisposing individuals to a wide spectrum of cancers, including glioblastoma. Familial adenomatous polyposis, caused by mutations in the APC gene, primarily increases colorectal cancer risk, but also carries a glioma risk. Lynch syndrome, resulting from mismatch repair gene mutations, similarly elevates risks for various malignancies, including gliomas. Neurofibromatosis type 1, due to NF1 gene mutations, is also linked with an increased incidence of gliomas, particularly low-grade tumors, but occasionally glioblastomas. While these syndromes are rare, taking a thorough family history remains crucial. When hereditary cancer syndromes are suspected based on clinical presentation or family history, referral for genetic counseling and targeted germline testing is warranted. This approach enables tailored surveillance for patients and potentially affected relatives, optimizing early detection and management strategies. In summary, although hereditary predisposition accounts for a small fraction of glioblastoma cases, awareness of these syndromes enhances our comprehensive care and informs patient counseling. Please let me know if you would like notes for any other slides or additional details. Certainly, here are the detailed speaker notes for slide 32 on the WHO grading criteria for IDH-mutant oligodendrogliomas. Slide 32 focuses on the WHO grading system for IDH-mutant oligodendrogliomas, a key subtype of adult type diffuse gliomas characterized by specific molecular alterations. Understanding the distinction between grade 2 and grade 3 lesions is critical for prognosis and management. Grade 2 oligodendrogliomas are defined by the presence of IDH mutations combined with the characteristic 1p/19q codeletion, but importantly, they lack features of anaplasia. Histologically, these tumors show low mitotic activity, no microvascular proliferation, and no necrosis. This lower grade correlates with a relatively more indolent clinical course, although these tumors remain infiltrative and incurable. In contrast, grade 3 oligodendrogliomas, also IDH-mutant and 1p/19q codeleted, demonstrate anaplastic features. They exhibit significant mitotic activity and may show microvascular proliferation and necrosis. These histopathologic signs reflect higher tumor aggressiveness and warrant more intensive treatment approaches. From a molecular standpoint, these tumors harbor IDH1 or IDH2 mutations, which drive oncogenesis and define this glioma subset. The 1p/19q codeletion is pathognomonic for oligodendrogliomas and is associated with better prognosis and chemosensitivity compared to astrocytic tumors. Additional molecular alterations often found include TERT promoter hotspot mutations, CIC and FUBP1 gene alterations, which further refine diagnosis and may influence tumor behavior. Calcifications are a common imaging finding, often visible on CT scans, which can aid in differential diagnosis. In summary, integrating histopathologic features with molecular markers as outlined in the 2021 WHO CNS classification allows for precise tumor grading and tailored patient management strategies. This molecularly informed approach represents a significant advance over prior purely histopathologic. As we discuss the multidisciplinary team approach to managing adult type diffuse gliomas, it's crucial to emphasize that these tumors present complex challenges requiring coordinated expertise across specialties. Neuro-oncologists play a central role in medical management, overseeing chemotherapy regimens tailored to molecular tumor profiles, such as IDH mutation status, which increasingly guide treatment decisions. Neurosurgeons are vital for obtaining diagnostic tissue through biopsy and achieving maximal safe resection, which remains a cornerstone for both diagnosis and improving survival. Radiation oncologists design and deliver precision radiation therapy, balancing tumor control with preservation of neurological function. General neurologists focus on symptom management, particularly seizure control and neurological deficits, which significantly impact quality of life and require ongoing monitoring. Supporting specialists enhance comprehensive care. Neuroradiologists provide detailed imaging interpretation critical for diagnosis, surgical planning, and treatment response assessment. Neuropathologists perform definitive tissue diagnosis and molecular profiling, essential in the 2021 WHO classification system that integrates histologic and genetic data for accurate tumor categorization. Oncopsychiatrists address behavioral and psychiatric symptoms, which are common and often underrecognized in glioma patients, ensuring psychosocial support. Epileptologists bring specialized expertise in managing complex seizures that can be refractory in this population. This multidisciplinary collaboration allows us to translate advances in molecular biology into individualized treatment strategies, optimize symptom control, and improve overall patient outcomes. Despite the aggressive nature of these tumors, it truly exemplifies the holistic and integrated approach necessary in neuro-oncology today. As we review the key clinical takeaways and evidence-based recommendations for adult-type diffuse gliomas, it's important to emphasize the complexity of accurate diagnosis. Integrating clinical presentation, advanced imaging, histopathology, and molecular profiling is essential. This multidisciplinary approach allows us to precisely classify gliomas, which informs prognosis and guides therapy. MRI with contrast remains the gold standard diagnostic tool. Its superior sensitivity helps delineate tumor extent, differentiate glioma subtypes, and identify features such as necrosis and edema that are critical for treatment planning. While CT scans may be used in emergencies or when MRI is contraindicated, they lack the detail necessary for comprehensive assessment. Maximal safe surgical resection is foundational in glioma management. Removing as much tumor as possible improves survival and facilitates molecular diagnostics. For glioblastomas and IDH-mutant gliomas alike, surgery sets the stage for subsequent therapies. Following surgery, adjuvant chemoradiation per the STOP protocol, combining temozolomide chemotherapy with radiation, is the current standard for newly diagnosed glioblastomas, offering the best chance to extend survival. Molecular markers have revolutionized our approach. IDH mutation status not only distinguishes tumor subtypes but also provides robust prognostic information and influences treatment decisions. Similarly, MGMT promoter methylation status is a predictive biomarker, especially valuable in older patients, as it helps us anticipate response to alkylating agents like temozolomide. Given the complexity of care, a multidisciplinary team, including neurosurgeons, neuro-oncologists, radiation oncologists, neurologists, and supportive care specialists, is indispensable for optimizing outcomes. Finally, clinical trial enrollment should be strongly encouraged. Emerging targeted therapies tailored to specific molecular alterations hold promise to improve prognosis and quality of life, marking an exciting frontier in glioma treatment. Together, these principles form the foundation of modern personalized care for adult diffuse glioma patients. As we conclude today's presentation on adult type diffuse gliomas, I want to emphasize the critical role that evidence-based medicine, molecular insights, and multidisciplinary collaboration play in advancing patient care and outcomes. Over recent years, our understanding of gliomas has evolved significantly, moving beyond histology to incorporate key molecular markers like IDH mutations and 1p/19q codeletions. These advances have refined tumor classification and prognostication, allowing us to tailor treatments more precisely. However, despite these molecular breakthroughs, it is important to recognize that adult-type diffuse gliomas, particularly glioblastomas, remain formidable challenges with limited curative options. The median survival for glioblastoma patients still hovers around 15 to 18 months, underscoring the urgent need for ongoing research and novel therapeutic strategies. The complexity of these tumors necessitates a multidisciplinary approach involving neuro-oncologists, neurosurgeons, radiation oncologists, neurologists, and supportive care teams. As general neurologists, you are often the front line in recognizing clinical presentations such as new onset seizures or focal neurological deficits and facilitating timely diagnosis with advanced imaging and molecular profiling. I encourage you all to engage in the discussion, share your experiences, and ask questions. Together, through collaboration and continued research, we can improve the trajectory for patients facing these challenging tumors. Thank you for your attention and dedication to this important field.